Chapter 16. Basic cardiac monitoring, the electrocardiogram. Key terms. Action potential. Processes of depolarization and repolarization of the cardiac membrane. Arrhythmia. Irregularity of cardiac actions associated with physiologic or pathologic interruption of the neuroconductive tissues of the heart, also synonymous with dysrhythmia. Asystole. There is no evidence of any cardiac neuroconductive activity, full cardiac arrest. Automaticity. Process whereby cardiac cell membranes spontaneously depolarize at recurrent periods. Bradycardia. Slowness of the heartbeat, as evidenced by slowing of the pulse rate to less than 60 beats per minute. Cardiac cycle. Events that occur from the beginning of one ventricular contraction, systole, until the beginning of another. Cardiac output. Amount of blood ejected from the ventricles each minute, calculated as the product of stroke volume times heart rate. Depolarization. Myocardial cells are stimulated to contract. Fibrillation. Quivering contraction of cardiac muscle fibers. Repolarization. Myocardial muscle cells relax. Tachycardia. Heart rate above 100 beats per minute. Basic cardiac monitoring, the electrocardiogram. Cardiac output is the product of heart rate and stroke volume and is the vital event necessary to maintain blood flow throughout the cardiovascular system. To accomplish adequate cardiac output, there must be adequate blood volume and a regular cycle of muscular relaxation and contraction. Assessment of the heart's ability to perform its vital function is possible using a device called an electrocardiograph, which produces an electrocardiogram, EKG or ECG. Historically, EKG was the abbreviated term commonly used to describe the electrocardiogram, based on the Greek term cardia for heart. However, based on English versions of medical terminology, the word cardia is used to refer to the heart. Today, both abbreviations, EKG and ECG, are used synonymously. For the purposes of this text, ECG is used. Principles of cardiac function. Although the heart is a complex organ, its purpose is simple: to pump blood through vessels to vital organs and tissues. Through the pumping of blood through the vascular system, a pressure, systolic blood pressure, is created that can easily be assessed using a stethoscope and sphygmomanometer. Systolic pressures greater than 90 mm Hg and diastolic pressures greater than 60 mm Hg generally ensure adequate perfusion of tissues. For systolic pressure to be sustained, the sequence of cardiac events must remain normal. This sequence of events is known as the cardiac cycle. In practice, the term cardiac cycle refers to events that occur from the beginning of one ventricular contraction, systole, until the beginning of another. The ventricles fill with blood during rest, diastole, and eject blood into the pulmonary artery and aorta during systole. However, a cardiac cycle includes many complex events that specifically occur to maintain normal cardiac output. Classic events required for a normal cardiac cycle are the rhythmic contraction and relaxation of the chambers of the heart, the atria, and the ventricles. The heart is composed of two principal cell types: working cardiac cells, and specialized neural conductive cells. Working cells are the cardiac muscle or myocardium of the atria and ventricles. Specialized cells include the sinoatrial, SA, node, atrioventricular, AV, node, bundle of His, and Purkinje fibers. These cells originate in and transmit electrical impulses across the myocardium and regulate the rhythm of a cardiac cycle. To initiate the neural conduction process throughout the myocardium, the specialized neural cells possess the ability to spontaneously originate electrical impulses. This action is independent of any nerves or hormones. However, actual firing rates can be influenced by the autonomic nervous system. The autonomic nerves include sympathetic and parasympathetic fibers. Sympathetic nerves can increase activity or rate of cardiac impulses, whereas parasympathetic nerves slow their rate. Each cardiac cycle begins with a spontaneous neural impulse generated by the SA node. Subsequently, this impulse spreads throughout the remainder of the cardiac neural conductive tissues, stimulating the muscle, myocardial, cells to contract. Abnormalities within the neural conduction system will adversely affect cardiac output. These abnormalities are called arrhythmias or dysrhythmias. The terms are used synonymously. Electrical membrane potentials. To comprehend the electrical impulses and the information provided by an ECG, one must understand the basic concepts regarding electrical membrane potentials. All cell membranes are positively charged on their outer surface owing to the relative distribution of cations. This resting membrane potential is maintained by an active transport mechanism called the sodium-potassium ion pump. When the cell is stimulated, movement of ions in and out of the membrane alters its charge, reversing the resting potential. This period is referred to as depolarization. When depolarization occurs, myocardial cells are stimulated to contract. The depolarization period is short. Reversal of ion flow re-establishes a positive charge to the outside of the membrane, a process called repolarization, which returns the membrane to its resting potential. During repolarization, myocardial muscle cells relax. The processes of depolarization and repolarization are collectively referred to as an action potential. This event perpetuates itself as an impulse along the entire surface of a cell and from one cell to another, provided cell membranes are connected to one another. The following steps summarize the action potential sequence. 1. The resting cell membrane is charged positively on the outside and negatively on the inside. 2. After stimulation, positive ions enter the cell, reversing this polarity. 3. This process continues until the entire cell membrane is depolarized. 4. Ions return to their normal location, and the cell repolarizes to its normal resting potential. Unique to the tissue of the cardiac neural conduction system is a process called automaticity, which allows cell membranes to spontaneously depolarize at recurrent periods. Another unique feature of this specialized tissue is that cell membranes are in direct contact with cardiac muscle, and their action potential directly initiates depolarization of the cardiac muscle cells. Cardiac muscle cells are fused to one another, which allow the cells to function as a continuous sheet of cells, a syncytium. The sheet of cells of the atria is separated from that of the ventricles by a layer of connective tissue that acts as an insulator. The SA node initiates depolarization of the atrial muscle, but the insulation prevents transmission into the ventricles. The AV node delays and finally relays the impulse along the common bundle of His, which penetrates the connective tissue to enter the ventricles. The impulse continues along the common bundle of His and its branches until it finally reaches the Purkinje fibers, stimulating the ventricular muscular sheet. Action potentials that spread throughout the muscle sheets of the heart may be detected by surface electrodes to record and produce a tracing known as an electrocardiogram. What is observed in an ECG tracing is the action potentials of the atrial and ventricular muscle cells. However, other events can be deduced from the tracing. Electrocardiographic tracing. The electrical sequence of a cardiac cycle is initiated by the SA node, known as the pacemaker of the heart. This is because the SA node has a faster rate of spontaneous firing than the remaining specialized tissues. The baseline of an ECG is called the isoelectric line and signifies resting membrane potentials. Deflections are the positive or negative changes in the tracing relative to the isocenter over the time of the cycle. These deflections are lettered in alphabetic order, and after each the tracing normally returns to the isoelectric point. P wave. The first deflection, the P wave, represents depolarization of atrial muscle cells. It does not represent contraction of this muscle, nor does it represent firing of the SA node. These events are deduced, based on the shape and consistency of the P waves. The assumption is that the SA node fires at the start of the P wave and atrial contraction begins at the peak of the P wave. Although atrial repolarization follows depolarization, the ECG provides no evidence of this event because atrial repolarization is too minor in amplitude to be recorded by surface electrodes. QRS complex, T, and U waves. The QRS complex represents depolarization of ventricular muscle cells. The Q portion is the initial downward deflection, the R portion is the initial upward deflection, and the S portion is the return to the baseline, isoelectric point. Often the Q portion is not evident, and the depolarization manifests as only an Rs complex. In any case, the complex does not represent ventricular contraction. The assumption is that contraction will commence at the peak of the R portion of the complex. After depolarization, ventricular muscle repolarizes, and this event is significant enough in amplitude to generate the T wave on the ECG tracing. Although not always seen, the U wave is typically small and, when evident, follows the T wave. The U wave is theorized to represent repolarization of the papillary muscles and Purkinje fibers. PR interval. The PR interval is measured from the beginning of the P wave to the beginning of the R portion of the QRS complex. This is conventional practice because the Q portion of the complex is so frequently indiscernible. Because the PR interval commences with atrial muscle depolarization and ends with the start of ventricular depolarization, it can be assumed that the electrical impulse passes through the AV node into the ventricle during this interval. If the PR interval is prolonged, it can be deduced that AV block is present. Summary of events of a cardiac cycle. Of the following 8 physiologic events listed for a cardiac cycle, only 3 are actually observed on an ECG tracing. 1 SA node initiates impulse, fires 60 to 100 times per minute, not visible on ECG tracing. 2 depolarization of atrial muscle, P wave. 3 atrial contraction, not visible on ECG tracing. 4 depolarization of AV node, fires 60 to 80 times per minute, and common bundle, not visible on ECG tracing. 5 repolarization of atrial muscle, not visible on ECG tracing. 6 depolarization of ventricular muscle, QRS complex. 7 contraction of ventricular muscle, not visible on ECG tracing. 8 repolarization of ventricular muscle, T wave. Analysis of the electrocardiogram. How one chooses to analyze an ECG rhythm strip is arbitrary. Each clinician must adopt a sequence of analysis that accommodates personal methods of reasoning. Always keep in mind that events during the PR interval pertain to supraventricular activity. When abnormalities are detected, try to establish the event as either ventricular or supraventricular in origin. What follows is a description of an ECG tracing, described for convenience as a 5-step analysis. Step 1, is the rhythm regular or irregular? If the intervals between QRS complexes, RR intervals, are consistent, ventricular rhythm is regular. If intervals between P waves, PP intervals, are consistent, the atrial rhythm is regular. Step 2, are all QRS complexes similar, and are they narrow? The duration of the QRS complex should not exceed 0.12 seconds, 3 small squares. A widened complex indicates ventricular enlargement, hypertrophy, or that ventricular depolarization is being initiated by pacemaker tissue below the AV node, for example, ventricular paced rhythm. In this example, one ventricle depolarizes first and the current must spread into the second ventricle. This takes more time than when the current spreads down the bundle of His into both ventricles simultaneously. If QRS complexes are narrow, the rhythm is being initiated by a pacemaker at the AV node or higher and is described as a supraventricular rhythm. If the complexes are wide, the pacemaker is in the ventricles and is described as a ventricular rhythm. Should complexes vary in appearance, more than one pacemaker is generating impulses. This is referred to as ectopic pacemakers, and the rhythm is described as ectopy. Step 3, are all P waves similar, and are PR intervals normal? If P waves are all similar, and normal in shape, one can assume that the SA node is the primary pacemaker. In this case the rhythm is sinus. If P waves vary in shape or are absent, other tissue, S, function as pacers. The PR interval is normally 0.12 to 0.20 seconds, 3 to 5 small squares. Longer intervals indicate that the impulse is being delayed from entering the ventricles, and the condition is designated AV block. Step 4, is the rate normal? Provided rhythm is regular, count the number of large squares between QRS complexes and divide this number into 300. However, if the rhythm is irregular, count the number of QRS complexes in a 6-second segment and multiply by 10. Rates below 60 beats per minute, BPM, indicate bradycardia, those above 100 BPM indicate tachycardia. Step 5, do waves and complexes proceed in normal sequence? Each P wave should be followed by a QRS complex, which is followed by a T wave. This ensures a normal sequence for each cardiac cycle. Common arrhythmias and the electrocardiogram. To recognize abnormal tracings, it is important to first observe a normal ECG pattern. Common treatments of cardiac arrhythmia. Cardiac arrhythmia is caused by abnormalities of the heart that negatively interfere with its neural conduction system and consequently affect cardiac output. Arrhythmias are typically classified by the origin of the abnormality, atrial or ventricular, or are classed by the speed of the resulting heart rate. Tachycardias may involve the atria or ventricles, whereas bradycardia typically involves either SA or AV node abnormalities. Depending on the cause and the severity of the arrhythmia, treatment may be as simple as administering antiarrhythmic medications, but it may also require more physical and invasive forms of therapy, including cardiac surgery. Cardioversion therapy is useful for treating atrial-related causes of arrhythmias, including atrial fibrillation. It involves external shock therapy to the chest to restore normal cardiac rhythm. In severe cases of ventricular tachycardia or fibrillation, electric shock defibrillation therapy is administered. Ablation therapies involve either heating or freezing tissues within a chamber of the heart that is considered to be the cause of the arrhythmia. Catheters are advanced through the vascular system into the involved chamber of the heart. Most frequently, radiofrequency ablation, RFA, is performed. RFA involves the use of electrodes at the tip of catheter wires. These are heated with radiofrequency energy, high-frequency AC current. Whether heating or freezing, the involved tissue is ablated, and the arrhythmia is resolved. Arrhythmias may also be treated with an implantable device such as a cardiac pacemaker or an implantable cardioverter defibrillator, ICD. A pacemaker is used most often to treat bradycardia. It consists of a small battery-powered generator to which 1 to 3 wires tipped with electrodes are attached. The battery and generator are implanted in a subcutaneous pocket near the clavicular region of the thorax. The wires are inserted and advanced through veins leading into the right cardiac chambers of the heart. In a single-wire unit, the electrode is placed in the right ventricle. In a dual-wired unit, the electrodes are positioned in the right atrium and right ventricle. In a 3-wired pacemaker, wires are positioned with electrodes in the right atrium and right and left ventricles. The battery and generator stimulate myocardial pacing of the heart. ICDs are typically used to treat tachycardia and irregular cardiac contraction disorders involving the ventricles of the heart, although ICDs treat bradycardia as well. Similarly to the pacemaker, the battery and generator are implanted in a subcutaneous pocket near the clavicle. Wires with electrodes are inserted and positioned in the ventricles of the heart, and the ICD monitors cardiac rhythm. In a case of bradycardia, the ICD sends a signal to pace the heart at normal rates. In cases of ventricular tachycardia or fibrillation, the ICD sends shocks to reset normal pacing. Summary. Assessment of the heart's ability to perform its vital function is possible using a device called an electrocardiograph. Systolic and diastolic actions of the heart pump blood through the heart and out to the lungs and body. Specialized neural cells possess the ability to spontaneously originate and transmit electrical impulses across myocardial cell sheets that generate cardiac muscle contraction. The SA node initiates spontaneous neural impulses across atrial muscle. The AV node relays the impulse along the bundle of His, which penetrates to enter the ventricles. The impulse continues along the bundle of His and its branches until it finally reaches the Purkinje fibers, stimulating the ventricular muscular sheet. Action potentials that spread throughout the muscle sheets of the heart may be detected by electrodes to record and produce a tracing known as an electrocardiogram. The ECG tracing consists of a P wave, representing depolarization of the atria, the QRS complex, representing depolarization of the ventricles, a T wave, representing repolarization of the ventricles, and sometimes visible a U wave, believed to represent repolarization of the papillary muscles and Purkinje fibers. Various abnormalities involving the electrical system of the heart can be detected through the ECG. These abnormalities are referred to as arrhythmias or dysrhythmias. Abnormalities of the heart that interfere with its neural conduction system cause cardiac arrhythmias. Treatments of arrhythmia are varied based on the severity and location of the disorder. Antiarrhythmic drug therapy, external shock therapy, and implanted devices such as pacemakers and ICDs have proved effective in the management of a variety of cardiac rhythm abnormalities.